thank you all for enabling me to come and talk to you today about issues with spasmodic dysphonia, focal dystonia of the larynx. It's kind of a very niche area within the field of otolaryngology, as Dr. Holds mentioned. My specialty area particularly is laryngology, so I spent additional time beyond my E and T training to really kind of focus exclusively on that T aspect. Just as a little bit of a primer, let's talk about the purpose of the larynx. Colloquially, it's known as the voice box, so we think about it for that purpose, but its primary purpose is to actually provide an airway, to protect the airway, and finally, the production of voice. And so no matter what we attempt to do with the larynx, we've got to be very careful about how an impact on one thing is going to affect the other. So the production of the voice, we have our resonator, that's up here, that's your head, that's your sinuses. You have the vibrator, which is the larynx itself, and then you have the actuator, the lungs, that's going to power it. Interestingly, if you take a larynx out of the rest of the body and then apply just air blowing through the vocal cords, it sounds like a duck call. So it's really, your voice is more than just what's happening here. It is all of that kind of being put together that creates the sound. So there's really two things that we need your larynx to do. We need it to abduct or open, and we need it to adduct or close. This is a normal female larynx. You'll see it opens when she takes a breath to allow air down into the lungs, and then when she goes to close, they come together and vibrate. So let's start to talk a little bit about the focal dystonia of the larynx, known as spasmodic dysphonia. There are approximately 50,000 cases in the United States. The vast majority of these are all known as the adductor type. There's a smaller group of the abductor, and then there's an even more rare group where they have both together, and that becomes incredibly challenging for us to be able to treat. In terms of the etiology, I won't belabor the point. You've heard this from many of the other wonderful providers here, but we know that the focal dystonias are diseases of the central nervous system, and in this case it's presenting as a focal spasm of the larynx, so a focal laryngeal dystonia. Although certainly we see cases of global dystonias and other neuromuscular disorders, Meigs syndrome in particular, we'll see patients also have spasmodic dysphonia. Rarely we will see medication toxicity cause this, but the vast majority is that primary type where it's caused by the central nervous system. In terms of typical characteristics, so our patients tell us that symptoms are worse when they're speaking on the telephone, periods of stress when they're having to kind of just be heightened. Symptoms can be improved in the morning, so the day will start off relatively well and then progressively worsen. They'll get a little better after ingesting alcohol. We don't generally recommend just drinking all day long to negate the symptoms. That doesn't usually bode well for occupational purposes. But patients will say, when I'm in a social situation, my voice is tremendously better if I've got just a little something on board. Interestingly, so singing and speaking, particularly in a lower voice, will generally create a more normal sounding voice overall. And so some patients will find that over time they've kind of developed more of a sing-song quality to their voice in an effort to try and mask what's going on. They usually can't maintain that for long, and family members get tired of hearing the sing-song. So then they come and talk to me. And 16% of my patients will generally have a dystonia elsewhere in the body. So let's talk a little bit about the two different types, kind of how we tease that out and what it sounds like. Fortunately, I do have some clips. Unfortunately, we can hear the clips because while I can mimic some of these, they can get a little challenging. So really, the primary diagnosis of spasmodic dysphonia comes about through perceptual voice analysis. The exam you saw before of the normal female larynx, it's called a stroboscopy exam. And on strobe, we can rule out a lot of different kinds of vocal pathologies. And it's helpful to us in evaluating patients with spasmodic dysphonia because we really need to rule out a lot of the other things. But generally when I have a patient come to see me where there's this concern, it's all about what I hear. So in general, you need to see a provider who has a lot of experience with voice, and not every general ENT has that. They're certainly exposed to a decent amount of it in training, but don't forget that we're not just T, so a lot of time spent figuring out the ears, the sinuses and boogers and all of that, and so you only get a fraction of time spent on the voice. So we ask patients to repeat sentences to us that are phonetically loaded. We are trying to tease this process out of them. So sentences such as, a dog dug a new bone, we mow our lawn all year, the waves were rolling along and we rode along Rhode Island Avenue. Some tongue twisters for sure, and so if patients also happen to have some oromandibular dystonias, they're really struggling to get these out, so it can be a bit of a challenge. But let me play this for you and you can kind of hear what the sound is like.
The blues are on the key again. How hard did he hit him? We were away a year ago.
So you're hearing this really constricted sound, this spasming close. So this is why it's adductor type, because the patient's larynx is trying to actually squeeze harder in the creation of these sounds. So a dog dug a new bone is going to be, a dog dug a new bone. And there are some patients where this has been going on for so many years, you don't even really hear the breaks. It's just constricted all the time, no matter how they talk. And so it can be a real challenge for us and our speech-language pathologists to sometimes tease out how much of this is primary focal dystonia, how much of this is a compensatory muscle tension dysphonia on top of it. The abductor type is certainly a much more interesting one. So this one, abductor, we're talking about opening. And so what happens, patients will go to say certain types of words and the whole larynx will just open up. So it's almost like their voice becomes breathy out of nowhere and cuts out on them. So it's keep Tom at the party, or put the cookies in the tin, or Sam usually takes coffee with sugar. So here's
60, 61, 62, 63, 64, 65. What did you do? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
So in general, what a lot of these patients will tell us is that depending on what it is they're trying to say, their voice will be better than others. And they haven't even necessarily thought about that until we ask them. And some will say, oh, I can barely even say my own name, but I can say my child's name just fine. And so it all has to do with the particular type that's going on. Treatment for this, like most dystonias, shocker, is botulinum toxin. Botox in particular, of course, as Dr. Gaza mentioned, is the Kleenex of our world. But in general, for treating most patients with spasmodic dysphonia, it really is Botox itself that we're using. Dysport and Xeomin had been used a little less frequently. Some of us will use it, particularly when patients are no longer responding in the typical way to standard Botox. But the dosing regimen is rather kind of different. With the use of botulinum toxin, we are using some really teeny tiny doses. So my starting dose for most patients with this condition is 1.25 units per side. And so we use a much more dilute version. So we dilute it with 4 milliliters of saline. So that is 100 units all in, or I'm sorry, 25 units per ml. Because we've got to be able to get that in there. Of course, the advantages to botulinum toxin, it's minimally invasive, doesn't require significant time. I can usually get this done within about 5 minutes in my office, assuming we're not having to deal with a lot of other stuff as part of that visit. Of course, we know that it requires re-injection every 3 to 4 months, and the possibilities for tolerance over time, that evidence is kind of mixed. By and large, the vast majority of my patients, we find stable dose somewhere between doses 2 and 3, and they usually stay at about that dose for years. Occasionally, we have to start bumping it up. In terms of the muscle groups that we target, so as I said, the vast majority of patients have that adductor type muscle group. And so those are the big muscles right in the middle of the vocal folds, the thyroarytenoid muscles. Most of us who do this do it under EMG guidance. So, hooking electrode pads up using an EMG-based hypodermic needle and sliding straight through. It sounds scary. It's actually better tolerated than you think it would be. Sometimes, for those providers who don't have an EMG machine in the clinic, they will sometimes do it by using a little camera in the nose, watching the larynx, and then pushing the needles through that way. To each their own. Everyone finds a way to be able to get it done. If we're targeting the abductor type, that one is a little bit more challenging. As I mentioned, the larynx has some other really important properties. That's providing and protecting the airway. And so the muscle groups that we have to target in patients with abductor type are in the very back of the larynx. And they're responsible for helping to hold the vocal folds open so that you can breathe. So if we're not careful about that dose, and because we have to target both sides, patients can actually get vocal folds that are paralyzed completely in the middle. So those patients might show up in my office suddenly going, having stridor, feeling very uncomfortable, feeling a sense of impending doom, and usually when I hear that, then I have my own sphincter tightening that's going on, and we have to figure out what to do about them. It's exceedingly rare, but it is one of the complications, not just with the use of Botox being injected into the larynx, but can happen as one of the distal effects of Botox. So as Dr. Gaza was talking about with spread of Botox, that is one of those things that can unfortunately happen. Interestingly, I've got a set of patients who have abductor type where we actually transition away from hitting those muscles in the back, the posterior cricoarytenoid muscles, and we target the cricothyroid muscles in the very front. Now those muscles are responsible for pitch elevation. So if I would have talked to you like this, I'm activating my cricothyroid muscles instead. And there's a colleague of mine about 6 or 7 years ago said that he had started targeting those muscles in patients with abductor type, and I said, I have no idea why that's working. That makes zero sense to me. And he said, I agree, it makes zero sense to me either, but it works and it's a whole lot easier. And you know what? He was right. I still have no idea why pitch muscles are going to help patients who are opening their vocal folds unnecessarily, but it's a whole lot easier to hit. Patients are a lot happier when we adjust from one side to the other, and it provides much more consistency and safety. There are, of course, some other things that are on the horizon. Well, actually, before things that are on the horizon, as I mentioned, alcohol. Don't walk around drunk all the time. I don't recommend it. But we do know that it improves voice symptoms in up to 58% of patients with spasmodic dysphonia and mixed spasmodic dysphonia tremor, but the benefits only last about 1 to 3 hours. So that's why you'd have to stay intoxicated all day long. So there is another drug on the market, Xyrem, known as sodium oxybate, which has shown some very fascinating promise. This is a very highly controlled substance. It is chemically similar to the neurotransmitter GABA, and it is FDA approved for treatment of cataplexy and narcolepsy, excessive daytime sleepiness. The reason that this is a highly regulated drug is that it is the sodium salt of gamma hydroxybutyrate, or GHB, or the date rape drug. So as you can imagine, we don't just want everybody in the world running around with this, and providers, physicians themselves, have to sign up on a special list with the FDA to be able to prescribe it. So far, 3 trials have showed a greater than 50% improvement in symptoms in those patients who have alcohol-responsive movement disorders. The effect usually comes in within about 30 to 45 minutes and lasts about 3 to 4 hours. As you can imagine, there can be some sedation, some dizziness, and variability in magnitude of effects. So Dr. Christina Simonian, who is a laryngologist and researcher at Harvard, her lab is actually doing quite a bit of work on this right now, looking at possibly trying to get an FDA indication for the medicine. I have had a few patients who've gone out and participated in the trial, and they swear by the effects of the drug. Now, they only got the drug for about a week. I had one gentleman in particular who suffered from pretty severe mixed spasmodic dysphonia with tremor. His poor voice was pitiful, and he had a near normal voice again while he was on that medication. So I think that there are some wonderful things on the horizon that will provide benefit to our patients. In general, surgery for this condition has incredibly mixed results. So certainly we have our own version of a myectomy that we can do. We have also tried selective denervation, renervation, where we actually go in and cut the recurrent laryngeal nerve, the big nerve going to the voice box, and then sewing it back together, and patients will have some temporary benefit. But I have a number of patients in my practice who had that done years ago and are still back having Botox with me. So I think for right now, botulinum toxin remains our mainstay of treatment, but there's some promising things on the horizon. With that being said, I greatly appreciate the opportunity that I had today to be able to talk to you about something that is certainly near and dear to my heart. Feel free to scan that if you need my contact information for any reason, and I'm happy to entertain any questions that you may have. Yeah, so certainly that is one of the concerns. So when we target the thyroarytenoid muscles and cause them to weaken, we decrease their ability to come together and close. So with too strong of a dose, patients will not only have a really sexy, breathy voice, but they are much more likely to aspirate, particularly on liquids. Solids not as much, but yeah, it's really hard to control the flow of a river, and thin liquids can find their way down much more quickly. In general, the way I target my dosing is to use the lowest possible effective dose in order to try and avoid that particular side effect. There are some other providers who go big or go home, and patients just know they're going to be super breathy for several weeks and may choke a little bit, but they may get a longer lasting result. Most of my patients are happier to come back a little sooner if need be, because we avoided the side effects of aspiration and breathiness. But yep, certainly possible.
Well, I think the good Lord gave some of us a combo meal with these dysphonias. Quick question for you. What does, if any, does the larynx and laryngospasms have anything, do they have anything to do with, let's say, your hypopharynx, or with, let's say, swallowing?
Yeah, in terms of, if you're having spasmodic dysphonia, and that's real, and is there a relationship with swallowing, or?
And let's say spasm of the hypopharynx.
Oh, spasm of the hypopharynx. So you're talking more like kind of cricopharyngeal dysfunction, kind of where the esophagus isn't opening up very well?
I'm an IT sales guy, so that last word just...
Yeah, okay. So in general, there's not a lot of hypopharynx. Yes, you can have some dystonia there. That's pretty rare. I've not actually seen a case of that. You have it? Yeah, wow. Yeah, so that hypopharynx is right there to the side of the larynx. So the musculature for that is you're going to get some similar branches, but in general, the laryngospasm there within the larynx, it will not necessarily mean you're going to get one within the hypopharynx. But yeah, I mean, if you're getting hypopharyngeal spasm, yeah, swallowing dysfunction is going to be a big one. And I'd actually be curious to know if you're having cricopharyngeal issues with that too, which is the sphincter right at the entrance of the esophagus.
When's your next appointment?
I can get you in soon.
Yeah.
Who determines that whether or not he has the words you said, crackle?
Yeah, so we see that on a modified barium swallow study.
Yeah, he got a swallow study performed, and that's where she noticed that, and I actually got the swallow study done, and they noticed that his hypopharynx was actually
Extra contractile, huh?
Yes.
I'd like to see that swallow study. Come find me.
That was fascinating. A couple questions. And Diane Reed, who used to be on NPR, is retired. She,
Yes.
I assume, had adductor variety.
Yeah, she had the adductor variety of it, correct.
About every 3 months, she'd be on there for 10 days.
Yep, she'd get
She'd
fairly
be
breathy.
And then she'd get tighter and tighter, and then she'd be off again.
Yep.
Your groovy that you're doing for your patients, has anybody tried that in like Blepharospasm? I mean, it sounds intriguing. Was it a lot of trouble to get?
Yeah, so I'm not on the list for prescribing it yet, although I may try and get signed up for it. They've had to go elsewhere to have that done. So, but yeah, there's a whole sign-up process you have to go through.
And what are your typical doses for these treatments? I promise I won't try to do it.
Yeah, so I generally will start, for most males, I'll start at about 1.25 per side. Females, I find, generally need a little bit of a higher dose, so I'll start at 1.875 per side, and that's for the adductor type. If I'm doing the traditional treatment for abductor, where I'm going behind the larynx to target the PCAs, I'll typically do 5 units on one side and 2.5 units on the other. And then when they come back for their next appointment 3 months later, we flip-flop with that. If I'm targeting the cricothyroids for that, then I do 2.5 units per side. So pretty small doses overall.
Most of the time I hear people talking about laryngeal dysphonia, I hear about how it affects the sound of the voice. My particular kind, I have adductor, and it doesn't affect my voice at all because every time I have a spasm, it completely closes, and I cannot breathe at all.
Yeah.
How common would you say that is, and is there any difference in treatment, or is it about the same as well?
So, in general, we put that on the spectrum of just laryngeal spasm. And I actually have a large population of laryngeal spasm patients, not necessarily where they're closing off as hard as what it sounds like you are, but it will definitely, you'll also hear it referred to as paradoxical vocal fold motion, or PVFM, which can kind of mimic asthma, or it can also cause chronic throat clearing. Interestingly, it's not always fully put into that category of a focal dystonia, although certainly, I think it's hard for us to know for sure under the kind of normal use cases that exist out there if it's really dystonia. I've seen it where it is, where you come in and I'll watch those suckers slam closed, and it's no wonder that you struggle. Botox also is, again, what I use for that. And in fact, for some of my patients who have PVFM, where laryngeal retraining therapy has not worked for them, we'll pretty quickly move to Botox to get it under control. But I think you bring up an interesting question, and as I think about it, I wonder how many of my patients really just had a very mild variant of the focal dystonia, and we're just kind of treating it in that more heterogeneous PVFM category. All right, thank you very much.
Yeah.